Well, welcome to our panelists for what I hope is going to be what I know is going to be a wonderful discussion happening in the midst of it's Air Quality Awareness Week. It also happens to be National Women's Health Week. So a lot of really timely conversation around health, wellness, and the air we breathe. And we're joined today by an epidemiologist, a dermatologist, and an allergist. So you might be asking, how do all of these disparate fields unite? And they're united all through the air we breathe. So there is a lot of commonality and room for really rich discussion in a topic that is becoming all the more important in our lives today. But I want to begin by introducing each of our individual panelists. So starting with Jessica Rivera. She is a microbiologist and science communicator with over 15 years of experience in infectious disease epidemiology, public health policy, and vaccine advocacy. She earned her master's in emerging infectious diseases from Georgetown University School of Medicine. She's a self-described data nerd, so shout out to another fellow data nerd, trained in science, and has used her growing influencer status to answer questions about mask wearing, vaccination, social distancing, and so much more through the course of this pandemic. So welcome to Jessica Rivera. And next on our panel, we have Dr. Robinson. Dr. Robinson is a board certified medical and cosmetic dermatologist in Chicago with subspecialty expertise in alopecia, preventative skincare, and ethnic skin dermatology. She's a graduate of Cornell University and University of Louisville, where she obtained her medical degree. Dr. Robinson is active in organizations such as Skin of Color Society, Women's Dermatologic Society, as well as the American Academy of Dermatology. So welcome, Dr. Robinson. And finally, last but certainly not least, Dr. Tania Elliott is a nationally recognized expert in the telemedicine and digital health space. She served as chief medical officer of the healthcare company EHE, where she re-envisioned and reshaped the annual wellness visit. And medical director of Doctor on Demand, seeing thousands of patients through real-time face-to-face video consultations and training hundreds of doctors on how to become telemedicine experts. Dr. Elliott graduated from Jefferson Medical College, completed her internal medical residency at Mount Sinai Hospital, and a fellowship in allergy clinical immunology at Winthrop University Hospital. So needless to say, again, I'm really excited to have you guys here talking about what I think is just such a rich topic as it relates to each of your fields and each of your areas of expertise. And I wanted to start kind of, where we're at this moment in time in life. We've been sitting in our homes, or at least in some sort of convoluted world of the pandemic life for the past year. I know things have changed dramatically for all of us. None of us could have imagined the kinds of lives we're leading today. So really want to ask, in your fields, in the work that you're doing as advocates for science, for health, for medicine, how has life changed in the course of the pandemic? And for what you're doing, how have things changed? And I'd love to start with you, Jessica, if you're willing to kick us off.
Sure. Everything is different, right? We are now in a reality where we've all are living through a global pandemic. It is something that I personally have professionally trained for in many ways. I studied emerging infectious diseases and I worked on trying to predict and prepare for emergencies like this. And we are here. And I think that we are still learning a lot of lessons about how we can prevent this from happening again and how to best respond and how to best communicate and how to heal from this. I think that there are a lot of open wounds right now, especially at this critical point in the pandemic, where we're trying to get as many people vaccinated, we're trying to get as many infections to decrease as possible, and all the while seeing the tragedy that's happening in India is a sobering reminder that this pandemic is not over, and that when there are places that are suffering, we're all suffering because this is a global pandemic. We're all very, very connected. One flight away from a pathogen kind of crossing borders. And we know that pathogens don't care about national borders, which is why I think at this point, it's of the utmost priority that the way we communicate and the way we even respond in mitigating this virus is thinking about equity, thinking about access, making sure that everybody is healing, so we can move forward and prevent this from happening again.
So yeah, I wanted to piggyback off that. I think that exactly what Jessica said, everything is different. As in dermatology, we've seen a lot of shifts just throughout the pandemic. First, at the beginning with hand washing, that was one of the first things that we were instructed to do. And we were seeing healthcare workers every day, people who were staying at home, just really struggling to do proper hand washing, and then the side effects of it with dry skin. And then we saw the spike in COVID toes that was getting some coverage, and people who genuinely had that manifestation or were concerned about signs they were seeing on their skin and what that meant. So we've seen so many unique skin changes that were not really talked about or really present before this time start to peak in dermatology. But
can I ask Dr. Robinson, can you repeat what are we seeing? Because do you say COVID toes? What is that?
Yes, so it's so we were seeing this phenomena where to the best of our knowledge, it was kind of a trigger that happened that was induced by the virus, where there was a little bit of ischemia or lack of blood flow to the toes, and it created these reddish kind of almost like broken blood vessel changes on the toes. And people were very concerned when this started getting some coverage in the media that they had it, and that, concerned about whether they had COVID related to that. And so we were seeing some patients, virtually and in person, with a lot of fear and a lot of concern about changes that they were seeing on their skin.
Wow. I did not know that. That's amazing. That's, fascinating, and also in some ways kind of scary to hear that we're learning more and more about how this disease can affect us. What about you, Dr. Elliott? How have things changed in the COVID landscape in the pandemic world for, I guess, telehealth and telemedicine in general?
Sure. I'll start though with allergy first, and how things have changed from an allergy perspective. One was pandemic hit right at the beginning of allergy season. And so people were coughing and sneezing, and they didn't know how to tell the difference between allergies and COVID. And then there was also the question of, if I have asthma, does that increase my chances of getting COVID? And so there were lots of concerns and scares around that. And then also just a bit of a stigma of having allergies, that if I'm going to sneeze in public, is everyone going to look at me and think that I'm spreading a contagious virus? And so there was a lot of education that we had to give to our patients. Certainly more people interested in treating their allergy symptoms, as opposed to just saying, oh, well, I'll just deal with it with rubbing my eyes and my runny nose and all of this. Number one, because if you're rubbing your eyes more and you're touching your face more, you're more likely to develop, to actually pick up an infection. But two, because there was such as I said, a stigma or concern that they were going to be perceived as somebody that has, is contagious or has a virus. And then interestingly, through the course of the pandemic, we've seen an increase in indoor allergies because lots of people decide to get COVID pets. So these furry pets were triggering allergies for people that didn't realize that they had indoor allergies. And also just by virtue of the way we're spending our days, more time indoors in our homes, exposed to indoor allergens, and then also more time outside, but that also meant more time outdoors. Socializing means more exposure to outdoor pollens. So it was a bit of a shift. And the good news is that wearing a mask can actually help with your allergies as well. So we actually have seen pretty good mask compliance with patients who have allergies. I'll pivot to telemedicine. And the truth is, my life really hasn't changed over the course of the last few years because I've been doing lots of telemedicine, but what has changed is people's understanding of the work that I do every day. And even non-healthcare professionals coming to me and saying, how can I communicate effectively through a video modality? How do I, make sure that I'm demonstrating skills of active listening? How do I make eye contact? Well, if I'm looking at you here, I'm actually not making eye contact with you, even though I'm looking into your eyes. If I look here, I'm making eye contact with you. So a lot of these skills that I've honed in doing telemedicine, these core communication competencies, were now being taught to physicians, and they were sort of open to that. How do I conduct a telemedicine visit? How do I develop rapport? How do I, demonstrate active listening with my patients? And then interestingly, folks outside of healthcare were looking to say, how can I improve my, effectiveness of my communication? How do I convey that I have a professional background, or, that I am still professional and that I'm getting my day-to-day work done? So all of a sudden I went from being this fringe doctor, oh, telehealth, what's that? You work from home, how do you do XYZ, to, well, now everybody works from home. And so, and there are pros and cons to that, especially as it relates to like just balancing the amount of work you have with some of your day-to-day responsibilities. And now it's okay for your dog to be barking in the background, or your kid to come running up next to you. But, and so, all of those aspects of sort of folks have now come to me, whereas previously didn't quite understand what I did. And now everybody's sort of very open to it. And so if there was any silver lining to COVID, it was, wow, there's a way in which we can leverage technology to bring healthcare into the homes. And we found a reduction in no-show rates for patients. So, patients who had social determinants, barriers to coming in because of childcare responsibilities, now suddenly are seeing their doctors because they don't have some of those barriers. People with barriers as it relates to transportation to getting into their doctor, they're showing up now because their visit is just one click away. And so we've really seen an increased adoption of telehealth visit for patients who have had challenges traditionally in getting in to seek care. And we've seen that both patients like it and doctors like it. So there will be a future where healthcare is delivered sometimes in the office, and then lots of times in the home.
That's fascinating. And I mean, in some senses, it's an acceleration of something that probably should have had happened long ago. From that perspective, I found something that all of you kind of touched upon very interesting, which is, or for me personally interesting, is that I feel like in the midst of the pandemic, we've kind of our bubbles have become even more bubbles. And I'm learning things just from talking to you that I didn't know about COVID toes, or I didn't know about the fact that indoor, like the COVID pets and the allergy triggers that are happening from that. So I'm curious to kind of expand my bubble and expand my knowledge. How do you guys see things changing in terms of the link, and a lot of the links in all of this, which is the air we're breathing? Has that dialogue changed in the past year? Are we thinking about this the right way yet? Or are there still more things we need to think about when it comes to our health and wellness?
I mean, if I could say something on that, it's interesting that now epidemiology is like a word that everybody knows, and public health is a conversation that people are having, while they're having their Zoom happy hours and talking to their family members and household members. And for many of us who've been in the public health space, we've known that things like air quality are related to public health issues, which are related to social justice issues, and that these things kind of speak to each other, they influence each other, and can create either worse outcomes, better outcomes, in a way that like we've never looked at things like health in a myopic way, right? It's a very multifaceted, multidisciplinary world. And I think now that that's on the forefront, I'm actually seeing a lot of people saying, I didn't know that epidemiology could involve things like this, or public health could also do things that are related to, social justice issues, and people applying to MPH programs and PhD programs because they didn't know that there's so much intersectionality here. And that, even when we're talking about things like COVID-19, that when we talk about access to things like vaccines or appointments to vaccines, or even getting good care at a hospital, getting access to a test, there's so many things around it in society, in infrastructure that can either, change the data or, make it better or make it worse. And as somebody who spent the entire year looking at the data, looking at the numbers and trying to find trends, we did see that there were some pretty noticeable lines of kind of poor outcomes, disproportionate burdens, and we can make a lot of links to those outcomes being worse in areas where things like air quality were bad. I think there's a lot of common denominators here, especially when we're dealing with something like a respiratory virus.
Do you feel like, Jessica, to follow on that, do you feel like we would have we've seen these disparities now, and it's obvious the racial lines that are drawn when it comes to the access people have to a lot of basic needs, including clean air. Do you think were we discovering this beforehand, or did it literally take a pandemic to highlight this? And if so, how do we exit the pandemic with a solution and actually come out feeling like we have ways to address these inequities?
I mean, that's the $1 million question, right? I would think that many people, all of us on this panel, would say that racism and that inequality are underlying conditions of COVID-19. And it unfortunately did take a pandemic for a lot of those underlying conditions to surface and to show their true colors of why certain communities were suffering more and why they continue to suffer more. It's nothing new for people who have been studying this. There's whole worlds and disciplines like social determinants of health that have focused in on these things to understand why these patterns happen in health outcomes. But it sadly did take a pandemic to kind of point everybody's gaze in that direction.
And I actually, Dr. Robinson, we've also talked about this before, in your work in dermatology, because I think, this is probably one of the few areas that would be unexpected when you think about air quality, and talking about air quality is also thinking about our skin and how our skin health is doing. But you've talked a lot about how there can be, these mass disparities. So just, can you help educate us on, first, even just the link between air quality and skin health, and then also, elaborate on then how do we see that play out in the real world when it comes to access to affordable care for these kinds of conditions when it comes to being exposed to poor air quality?
Yeah, I think that, in dermatology over the past decade, we've started to more closely look at the link between pollution and skin health. And in particular, like, we knew for a long time that cigarette smoke, for example, was linked to many skin conditions. And then UPFs, ultrafine particles linked to certain skin cancers. But now we are seeing the link between particulate matter. And that's very key, because it can actually directly contribute to inflammation, pro-inflammatory cytokines, and it can contribute to reactive oxygen species. And so that's going to impact both inflammatory skin conditions, but also skin aging. And in dermatology, I think that the focus on the impact of that is starting to broaden. But when we're talking about access in dermatology in general, there is a huge disparity that the specialty is focusing on addressing. There's a disparity with patients having access to dermatologic care in general, both in urban and rural areas. And there is also a lack of representation amongst dermatologists, particularly dermatologists of color. So I think that when we're thinking about some inflammatory conditions like eczema, and we're seeing that these conditions are disproportionately more difficult to treat in patients of color, and that we are seeing them linked to areas that have higher pollution rates, like urban locations. We really need to have that access for patients so that we can get them the care that they need. So I think, it's a huge undertaking, but we are definitely focusing in on addressing it.
And can I, for a layman like myself coming into this, can I clear up some, can you help me clear up some misconceptions? Like, this is not just a vanity metric, like, oh, I want to have healthy skin. There's actual real consequences to our skin health when we're talking about, all of these conditions that you're working on helping people overcome and treat.
Oh, yes. Yeah. I mean, inflammation in the skin, we know drives eczema, psoriasis, lots of conditions that actually impact the quality of life of the affected individuals, and it is not a vanity issue at all. And so I think that's a good point that needs to be cleared up.
I think that, you guys have highlighted one of the issues that I think is becoming increasingly, I guess it's close to my heart. I know that for a lot of people, we're waking up to the realities of the disparities in this pandemic. But I want to ask and push a little bit just to say, like, how do we solve this? Like, what are, I know that it is a lofty question, and it's not something that we can say overnight. Yeah, okay, we can fix it with a magic wand. But if there were some kind of like things that we could do as individuals or as a society and collective, what would you guys suggest?
Better data for me. I mean, we can't make policy changes. We can't inform budgets without data, right? And we have not had good data throughout the pandemic, and we continue to not have good data because of how our census is defined, how the census defines demographics. And so I think until we get better representative data on a granular level, knowing who, where, why, how people are getting care or not getting care, and their outcomes, it's going to make it really difficult to kind of create tailored policies and changes in those zip codes that we see the worst outcomes.
Mm-hmm. Mm-hmm.
Yeah.
Actually, yeah, go ahead.
Yeah, I agree. I mean, when we're talking about, inequities in medicine, a lot of the fabric of that is the systems that are in place that are preventing certain groups from getting the care that they need. And in order to change those systems, we need evidence in the form of data, so that people who, only realize that these inequities existed because of a pandemic can have the numbers in front of them that are undeniable, that we can then use to drive change. So I think that's very important, what Jessica highlighted.
That's an interesting point. It's also, you're right that I think, I've in the past year started seeing more, there was just a recent report published by a number of universities. I think Berkeley was part of that, and talking about air inequalities and how the disparities are so stark and so obvious, and it's leading to really poor health outcomes. I'm curious, Dr. Elliott, from your perspective with the telehealth world and telemedicine world, is that opening up opportunities for us to kind of shed some of these disparities, or where do you see the future of that going to be able to help, address, some of these problems we're seeing?
Yep. And so we absolutely need more data. However, the ways in which we capture data are currently inefficient.
Yep.
And so we need to leverage technology to get real-time data and real-time insights. If we want to understand the air quality of the home, like there are devices that are like fit on a keychain that we can evaluate air quality of the home. And so we recognize now that it's a problem. How can we leverage technology to gain those real-time data insights of what's going on in somebody's home environment? And I think that that'll probably come more from industry than it will from the traditional healthcare system that waits for a randomized controlled trial to even decide whether or not we should measure air quality in somebody's home, because we've never done that before. So it's almost with technology in healthcare, it's like, it's really a challenge, because the infrastructure that exists today with the way that we structure and we collect data does not account for our new ability to collect data in real time. So I think that it will come from consumers saying, I want to understand what the indoor air quality is in my home, and I'm going to purchase a device that's going to be able to do that. And we've seen lots of actually positive, tailwinds around this in what we call the remote patient monitoring space. And the FDA actually stepping up and saying, we're going to create a pre-check process, for lack of a better term, where companies can actually go through a process of creating FDA cleared devices so that you know that the quality of the device that you're using is accurate. So you're not, it's not a, some random device that's saying, oh, your CO2 levels are through the roof, but it's actually something that's been validated. Because the software or hardware companies sort of gotten a seal of approval. So we're seeing more and more, hundreds and hundreds of devices coming out, whether you're monitoring somebody's blood pressure or their respiratory rate, or the ambient environment and their indoor air quality. That all those pieces of data are now coming through, and I think it's going to be driven by industry and the consumer. And then around access in general and how to leverage technology to improve access to care. I alluded to it before, but the value of leveraging technology to bring care into the home. What I do with my patients is an environmental assessment. I say, great, flip your camera around. And we know, 90% of people have smartphones today. Flip your camera around, give me a tour of your home. Let me understand your living environment. Like, look, those vents need to be changed. When was the last time your vents were changed? Like the window seals there need to be fixed because you're, on a very busy, urban street. And, now you've got pollution coming in from your home there. So I can actually pinpoint and address those pieces. The only way we were able to do that previously, and there's literature to support that home assessments for patients with asthma and then targeted interventions can improve asthma outcomes. The only ways we were able to do that were like a nurse driving to somebody's house, showing up and actually pointing out those things. So you're unable to scale those kinds of programs. But with technology, we can see into people's homes. We can see into every single one of our patients' homes. And I would encourage physicians to recognize, telemedicine wasn't just for my clinic was shut down, so I had to convert to virtual care. There's a value add of virtual that allows you to see into somebody's home, to see their day-to-day interactions, to see their living environment. And that will then enable us to be better clinicians and diagnosticians. And when we think about treatment, we shouldn't just be thinking about a medication treatment. We should think about treatments as it relates to ways in which we can improve their home environment.
I'm really fascinated by this conversation because it took a turn that I actually wasn't even expecting. So as I'm listening to you guys, and feel free to challenge this, but part of what I'm taking away is that there's been maybe a void of data or a lack of data in some of these spaces. And while we may be as a society with writing and publishing papers, doing tons of randomized control trials and studying things, that infrastructure hasn't exposed some of these disparities. So I guess I'm a little bit surprised, and that we could have, is it inherent in our research process up until now that we were not able to see the racial disparities that we had in the healthcare system? Like, what failed to get to this point? Because from what I'm taking away, there's something even inherent in the way we do our RCTs and the way we do publishing that didn't allow for this metadata to come out. Is that too much of an assumption to make?
I don't think it's too much of an assumption. I think that was even demonstrated with the vaccine trials, right? They tried really, really hard to have really broad enrollment in all phases. And we saw in the early phases of the vaccine trials, it was not very diversified. It got more diversified where by phase 3, it was about 40% non-white participants, which is a really big improvement considering decades ago, what that looked like before. But we also have to acknowledge the fact that there's legitimate reasons why communities of color would not, voluntarily enroll in these things or would be hesitant to share their data. There's a historical trauma that we need to recognize. There's current trauma and mistrust that we need to recognize. And I think it's really important that we reshift that narrative to make it less about communities of color not being distrusting, but more that the medical community, healthcare community needs to earn that trust. And we can earn that trust by being extremely transparent about the data and being transparent about the uses of the interventions and the reasons why there's these invasive questions and, inquiries on their lives, because it is intended to help, right? There's a lot of, there's a lot of distance between kind of where people are who need help and where people who can provide that help are. And I think that bridge can happen with better communication. I think that when we think about science, when we think about data, it can be very kind of out of touch for a lot of folks because it's been treated as this only privy to a certain community with certain types of accolades and acronyms next to their names or letters and etc. And I think to not spend the time to translate that to folks and to communicate it and to make sure that it's accessible in multiple languages, regardless of ability, and to even in internet speed and ability to understand it based on like the actual language used. I think that there's so much that goes behind just that, data collection. It's like how it's used and how it can be given back to the community it's intended to serve.
Yeah, and I'd add to that because it's those pieces that we just need to get better about collecting the data and being transparent with that information and recognizing those inherent, those challenges and existing traumas associated with that. There's also a piece of it that this data, these opportunities didn't exist before. Like right now at your fingertips, look at all you can do at your fingertips on your smartphone. So you can have and the other piece is it's the data is then in control, in the patient's control. So I could decide to download a health app and enter in information about what I'm doing every single day, what I'm eating, how I'm breathing, how many steps I'm taking, what my posture is like, all of these things, and it's mine. And then I can choose to share that information with my healthcare professional. And those opportunities didn't even exist. So I think, empowering patients to be able to collect and have their own data that they feel can improve their overall health, and then them choosing to share that data with their healthcare professionals is going to change a lot of things. And it also just allows us the opportunity for us to not have to wait for science. Like oftentimes physicians are the stopgap. And, I think we could say this because we are doctors, but, it's sort of like we go to medical school, we learn this whole new vocabulary of words to say to confuse patients. Like, why should I should be relatable and approachable. If anything, I should be taught in medical school how to explain a concept to a patient instead of saying, well, you're hyperlipidemia and hypercholesterolemia, which is the same thing. It's, but all these sorts of terms that actually separate you from the patient and make it seem like you're the one that controls the data. It's this doctor-patient relationship of doctor knows best to then actually relationship-centered care. We'll let the patient be in control of their care, patient be in control of their data, their health data, and then they choose to share that with their doctor, and then you can have an informed discussion around that. So a lot of that is shifting and enabled by technologies, but we have to be smart about it. We don't want to just leave everything up to patients, and we also need to make sure that we, there's a balance of the information that's coming in and then the value that a clinician can provide. So it's not just all about the patient just getting the latest and greatest gadget and gizmo or app, or getting misinformation online, because that exists as well. So it really is a balance, but we need to sort of harness these opportunities now.
Well, I have to say that you kind of bridged really nicely into a topic that is near and dear to my heart. But it was a question, it was a thought that was triggered by what you all were saying, which is around this, around the fact that, first of all, there's 4 women in this panel, and accomplished scientists, medical experts on this panel. And that is something that I am so excited about because, you know, growing up, I don't think you necessarily were visibly shown those kinds of health and wellness experts as role models to talk to you about things that are very personal, which is obviously your health. So I'm curious, in your individual journeys to, you know, to bringing awareness around the fields that you represent, what has that journey been like as a woman or woman of color, and how have you, what kind of obstacles have you had to overcome? And there is a second question to this, but I want to ask that part first. Maybe Dr. Robinson, if you can kick us off.
I think I share a lot of the same experiences as the women on this panel, in that I was often the only one in the room, either the only woman or the only person of color or both. And even just like that intersectionality is, you know, kind of put some distance between you and the other people in the room in terms of how you relate and all of that. So throughout college, I went to an Ivy League college, which was a shift because I grew up in inner city Chicago. So I didn't really, and I went to upstate New York, and it was just a whole different environment over there. But then I went to medical school, and for a long time, you know, medical school has been male dominated. There was a slight lean towards women when I was in there, but definitely not diverse. And then I decided to apply to one of the most competitive specialties in medicine. And that it was even more, you know, kind of an only person in the room situation. So I think that with that came challenges, just trying to, you know, like from a dermatologic standpoint, trying to relate to my colleagues what a patient of color was experiencing, having to be that person unknowingly that had to explain what Black hair was like, or why a person with seborrheic dermatitis couldn't wash their hair every day with medicated shampoo, or just kind of like bringing that cultural competency back into care. So I think the experience is like something that I'm still, you know, like however many years out of residency, slowly unpacking. But I think it's something that I probably share in common with a lot of the women on this panel.
That's amazing. Thank you for sharing.
Yeah, it's very similar in that regard. I was often the only person in the room of whatever demographic it was that was not the, you know, majority. Woman of color with textured hair, all those things. I mean, my journey with my hair was like a whole emotional thing that happened after, you know, being in a work environment where I was told like, oh, you should probably straighten it for this really important meeting. And, you know, just had some really, really traumatizing work experiences that often made me felt like because of what I look like or who I am, that I should probably take a back seat or just not be as present in a room or in a space like, you know, whatever I was doing. And I think that informed a lot of my, you know, I was a little timid at the beginning of the pandemic to even start putting my face out there and be a spokesperson for data transparency and science communication. I had been so kind of bogged down by a career that didn't really prioritize that. And I'm also a mom of 2 kids, and I felt, you know, not really valued in that regard, as like, oh, well, you know, she's chosen motherhood instead of really climbing to the top of her career. And that comes with a lot of lies and, you know, insecurities too. And I think that after a lot of encouragement from peers and from people who actually knew me, it's proven to be an incredibly rewarding thing to put myself out there. And I've relearned that I have this, you know, muscle memory from years of studying and years of training, that actually this is what I love to do. And this is something that brings me a lot of joy. And to see people respond positively because of the things that made me feel insecure before, and thank me for, I've got tons of people who DM me saying like, I now have, a person to point my daughter towards when it comes to being a woman of color in science, or a science communicator, or an epidemiologist. And I cherish those memories. And I'm also very aware that I have a daughter who's watching me, and she's been within a few feet of me every single day since March of last year. And I get this, really unique opportunity to lead the way, to show her that there are examples of people like me doing the work that I do, that we can even do it full-time from home and have just as rewarding of a career.
That's amazing. And Dr. Elliott, do you have your journey and your story in all of this?
Yeah, I think, I decided that I wanted to sort of, to change healthcare, and that I wasn't okay with the status quo very shortly after I graduated my fellowship. I started off in private practice in New York City, and I said, this isn't really what I want to do. I wasn't crazy about sort of the structure of this fee-for-service world. The more tests you do, the more money you make. And I thought I was doing a disservice to my patients. It was this perverse incentive where I knew they didn't need a test. So why was I going to do it just for the sake of doing it? But I wasn't compensated for the time that I spent educating them. So I knew something had to shift. And then also just I felt handicapped when patients were physically coming to me. I wanted to say, I want to come to you. I want to see into your home. What does it look like? So I could identify environmental triggers that could be making their asthma or their allergies worse. So then I found telemedicine and virtual care and remote monitoring, and I kind of fell in love with this digital health space. The problem was that everyone was like, oh, this concept of like this fringe doctor who's adopting this technology. So I was trivialized a lot. And then it was also, well, you're young, you don't know, and you're a woman. So it was very hard for me to kind of, despite having seen 7,000 or 8,000 patients through video, training hundreds of doctors, I'd walk into a room and people would say, oh, you must be the nurse, or you must be the secretary of, like, who is the main event here? Who's the real? And it's like, no, it's actually me. And what it led me to, and I've also been in a number of conversations with like people that are in charge of benefits of large employers, HR departments, and I would have to kind of convince them of the value of telehealth. Why should I have this be a corporate benefit for my patients, or for my employees? And again, I would pop up on the screen and they would say, oh, come on. Okay. And kind of like, divert their attention elsewhere. So it really forced me to hone in on my communication skills and get them to understand the value of telehealth. It's really helped me to hone in that elevator pitch. And then also just kind of own who I am and be prepared to say, well, I understand, almost poke holes in our existing, system and say, well, would you rather wait 3 weeks to get in to see your doctor, or would you rather click a button and have your doctor pop up on a screen and you get the same level of quality care? So it forced me to get more creative about the best way to communicate with people, forced me to read my audience, forced me really to be really strong and kind of evidence-based and firm in my words so that people took me seriously. So, I think it ultimately made me a better communicator. But now I'm dealing with, the same things Jessica's dealing with, as being a working mom. And I've got 2 kids under the age of 2, and then 2 older stepdaughters. So every other weekend, it's 4 kids in the house. And I realized that I'm going to move away from the word work-life balance, because at the end of the day, it's life. And we have to just make decisions. And women are faced with sort of being the chief executive officer of their home, in addition to, our day jobs. And so I think we just need to own it and say, like, look, I'm from 3 to 3:30, like, I'm with my kid, but as soon as I put them back to bed, like, I'm going to be back and working, and that's just what you get. And kind of like owning that that's who I am, and that's my day-to-day life, and moving away from this kind of concept of work-life balance. Like, I am a working mother. I love my kids. I love my job, and I'm going to give 100% to whatever I'm dedicated to and focused on at that point in time. And I'm not going to hide it.
Yeah. This is all, I mean, I can just say I watched, there's a talk by Indra Nooyi, the former PepsiCo CEO, and she gives the best explanation of a working mom, exasperated, just like, sometimes you just, you got to cobble life together, and it's not perfect, and there is no silver bullet here. But I asked the question also kind of selfishly, in a sense, because one, I'm inspired by these stories, and it's definitely fuel and motivation for me personally. But two, also because I think that adversity, I think adversity also builds strength. Not that you wish it on anybody, but when people have gone through it, it builds strength, and it builds a muscle that you wouldn't otherwise have. And in today's day and age, when science has, I think, come under it's never been needed more, and it's also never been at the almost the brink of failing to communicate with people, for multiple, be it health, be it climate change, be it all sorts of different topics. So it's really important. And part of the reason why I asked that is I'm curious how this adversity, or how this kind of journey each of you has taken, has made you a better communicator of science, of health, and giving advice to people, than if you hadn't had that. So I'm really curious about that from any of your perspectives.
I mean, I've always been motivated by, in my work, the quote, science isn't finished until it's communicated, but I've kind of added to that and said, science isn't finished until it's communicated with empathy. And I feel like that is what's missing in a lot of people's understanding of how to translate, data, translate clinical findings, translate headlines and preprints, et cetera. And sometimes it means, being having empathy, but with a strong tone, and being like, hey, actually, this is harming people. We need to be protecting people in this way and standing up for them. And I will say, like, as a woman in epidemiology, there's a lot of armchair experts out there who are trying to, chase some clout for the pandemic. And, women end up getting called shrill and petty for speaking up. And I'm really tired of that, right? It's just an annoying normative stereotype that's thrown on women, when really what I'm motivated to do is, because people are so inundated with information, which in a pandemic, what always happens is a tandem infodemic. When there's an outbreak of a pathogen, you can expect an outbreak of bad information, misinformation, disinformation. And unless we are caring for the people who are drowning in both of those things, and say, hey, let me help you kind of find fact from fiction and move from fear to informed choices, so that people are not feeling overwhelmed, because pandemics are scary. Like, there's nothing as disruptive as a pandemic. I'm going to keep communicating, and I'm going to keep repeating myself, which is required in science communication, lots of repetition and a lot of empathy. And sometimes empathy means speaking very sternly against things that are intended to harm, things that are intended to dissuade and cause disruption and confusion. And I think that one of those lessons that's not taught in people's scientific training, whether it be medical school or graduate school, is the power of communication. We can really change the world of science if we're better at making sure that it goes all the way across that last mile. In the same way we talk about vaccines, it needs to get to every ear, every mind. And I am so thankful for people prioritizing that now.
Can I ask you, Jessica, was there anything that you feel like, particularly from your journey in the past, that gave you gave you the ability to communicate better because of where you came from, or because of the experiences you had?
I think being in the infectious disease world, and particularly vaccine preventable illnesses, is like a focus of mine. I've seen the power of misinformation and disinformation, and I've seen how it's targeted. It targets people of color, it targets moms, it targets women, it targets communities that are disadvantaged because of accessibility issues. And it's so sinister. And as somebody who fits a lot of those demographics, and as a mom myself, I find it to be very, very motivating for me to continue to be better and better as a science communicator, because I have seen kind of all the tactics to take people onto the dark side of the internet, to the dark holes of misinformation and disinformation. And I think my proximity to it for a number of years, knowing kind of the motivations, goals, sometimes even financial, has given me a new kind of sense of a new set of skills for that.
That's fascinating. Yeah, thank you. Do others feel like, I'm just curious if you guys have felt like anything specifically in your like a past experience or even a series of experiences that got you to now be able to give a message that otherwise, because health and wellness can also be in general a topic that is just overwhelming. I mean, I can't tell you, I just like open up, I'm probably following some people and apps that I shouldn't follow just because, if you look at the root of it, the data is not legit, but it's just, there's so much out there. So how have you found in your own personal journey that, that communication come through?
Well, first I want to say that I'm so amazed by all the women on this panel. I'm a mom as well, and you guys are doing incredible things. So moms can do amazing things too. And something that you said about like adversity building an extra muscle in us. And I think that is definitely true for each of us on here. But in terms of communicating, I think for me, I saw a lot of miscommunication in dermatology and like the traditional dermatology system, where you basically see a new patient every 10 to 15 minutes. And the time that you're in the room is maybe 2 minutes. So it's really difficult to communicate anything, especially about these complex like inflammatory skin conditions, or even just the treatment plan to a patient in that shorter period of time. So one thing that I did personally was I shifted my practice, much in the way that Dr. Elliott did. I shifted to a model that I felt was more effective and allowed a little more time to communicate with patients. And it's a direct care model. So with that, I don't contract with insurance companies. I like to say that I work directly with the patient, not for an insurance company. And I'm able to spend more time with them and just communicate like treatment plans and things. And the beautiful thing that has come out of that is we've seen throughout the pandemic that and I don't know if you guys have noticed this too, but there's actually a hunger for information, all types of information, but about the skin and like skincare and what's happening on my skin and maskne and what is this bump. And so I've been communicating scientific things, condition and disease specific things in a more digestible, like patient facing form on social media, inside and outside of the office. And I've had to really like change the way that I talk about skin conditions for people who've never really, been exposed to dermatology. So that's been kind of a positive thing.
Mm. Yeah, I can just vouch for being on the other side of that as a follower of yours, that it is really helpful. So so please keep giving that digestible information. Dr. Elliott, your journey and being a voice of science and health in the midst of like, I love, Jessica, what you said, an infodemic. We are over inundated and there's so much information out there.
Yeah, and I think it kind of just goes back to like, this concept of like being trivialized, young woman, doctor. And I've done a lot of media and, been like quoted in tons of magazines and things like that. But I was really playing small. I felt like it was like, oh, that's the cute doctor that talks about allergies. And so like, it's a really silly question. Like, if you sneeze, how far does your mucus travel? And, like really silly kind of trivialized things. And I think, then the pandemic hit, and I'm an allergist immunologist, and I was asked to kind of talk about, things related to, the vaccine and, is it airborne or droplet and this and that and all these things. And realizing that it was so politicized that I was pregnant with my son, and I just said, you know what, like, I'm not doing this anymore. I felt like I was being manipulated a lot on camera and being asked to say certain things. And it was really dependent on who my audience was and what show I was being asked to be on. So I said, I'm taking a break And so I'm actually going through my own kind of like rebirth, kind of taking all of this. It's been a traumatic year for all that, to say like, who am I? Who do I want to be? Like, where's the strength in my voice? And like, you know, who am I as like a physician scientist? And so where I've landed is, again, this huge opportunity in the digital health space, and kind of leveraging my experience over the last years around telehealth, around remote monitoring, about the power of data that exists in the hands of consumers and patients, and then this whole healthcare revolution. And so, you know, I think gone are the days of like the silly, you know, not that it's silly, but you know, this pollen count. And you know, I used to talk about, you know, scrubbing your eyelashes to get pollen outside of your eyelashes, and little things like that were really like fun little health hacks, and really more towards like being a voice of like, you know, how technology can really transform healthcare. So that's sort of what this journey has been for me.
I have to say, whether anybody enjoys this or not, I am having the time of my life just talking to you guys. It's fascinating. I mean, really, like you guys have each one of you, I say guys, you gals, we, as respected scientists and physicians, you all have become such inspiration, honestly, to a lot of us, because I think we're looking for voices of reason, voices of information that we can trust. And to the earlier point, like as a woman, I want to hear it from people who can relate to my journey, because it's different. And so I'm really appreciative of it. We have a few short minutes left. I want to do a quick kind of fun rapid fire with you guys, with you gals. These things are ingrained in my brain, but just some fun stuff to chat with you, and quick answers, like 1 minute max. But now that we're coming out of who knows, but wherever the pandemic leads, but whatever happens, the question is, what other type of apocalypses are you afraid of? So I'm going to start with our epidemiologist, because I'm sure you have some long laundry list of other apocalypses that you're concerned about.
You know, it's kind of funny because in grad school, you know, I remember being at parties and people being like, so you're studying infectious diseases, like, what are you afraid of? And I would say a respiratory virus that becomes a pandemic. And so, I mean, I've been thinking about apocalyptic global pandemics for probably a lot more time than many people who are not focused on emerging infectious diseases. But to be completely honest, it's something like this again. It's especially one that an extremely virulent, you know, respiratory virus that probably spills over from an animal species that takes a long time to contain and a long time to, you know, create therapeutics and vaccines for, sadly, 2.0.
Okay. Dr. Robinson, apocalypse?
Well, I think like most dermatologists, I'm mostly terrified at the complete disruption of the skin barrier that I'm already witnessing, actually, with just like poly skincare, poly exfoliation, and I think that has a whole slew of downstream effects. So, and it affects a lot of people. So I think that's something that is, that's apocalyptic to me.
Dr. Elliott, apocalypse?
Internet breaking. I don't know what I would do. My whole telemedicine thing's out the window. I got to go back and get my own doctor's kit. And I don't think I can figure out how to get around the corner without Google Maps. So that's the biggest thing for me. What happens if technology breaks down?
Yeah, nobody wants a Y2K if it actually ever arrives. Last two questions. If you could do away with one pollutant forever, if you could pick one pollutant in the air, what would that be?
My husband's gas. Is that one that counts?
That's a good one. We can put that on the list.
I'll just go for cigarette smoke.
Okay. Jessica?
Yeah, I mean, I'm allergic to so many things like dust and pollen, but I think probably smoke fire, which is not always in the air, but it is in the sense that, you know, our climate is really not doing well. And we have the fact that I live in California, the fact that we have wildfire season is a problem. And that, you know, for allergies and just even for our climate is really, really something I'd like to stop.
100%. Last question, best advice you were ever given. I'll start with Jessica. We'll go in the order we started.
Ask for help. That, you know, I strive for excellence all the time, like to do things on my own, and I don't like to ask for help, but asking for help, especially after I became a mom, was one of the best pieces of advice that I ever got.
Dr. Robinson?
Oh, I don't know if I'm going to say this exactly right, but it's something like you miss 100% of the opportunities that you don't take. So that's stuck with me.
Dr. Elliott?
I think it's my life's been filled with so many misfortunes, many of which never happened. So not worrying about things that might happen and just go for it and just own it.
Well, look, thank you all for making the time to speak with us today and educating us and enlightening us on what are just such important aspects of our life now, especially in the pandemic world with health and wellness. And wish you all continued success in all your endeavors to continue to advocate. Thank you.
Thank you.
Thanks for having us.
Thanks.